We will move on to the last speaker of this session, Dr. Sambit Sahu. Sambit is a dear friend. He is the medical director and chief consultant critical care at KIMS Hospitals, Hyderabad. His interests are liver transplantation and ECMO. He has got 5 international publications. Pleasure to hear from you, Sambit.
Thank you, sir. So, the last topic of the day, pharmacology. Thankfully, the last topic. Thankfully, the last topic. It's actually a very strange topic. When, as delegates, you or speakers, you go through the schedule and you find a topic like this, it's okay. And we generally categorize it as a Gyan topic. So, the disclaimer of this topic is use logic at your own risk. Because whatever science you apply or logic you apply, ultimately it boils down to rote memory and again going back to your textbooks and reading about it. Sometimes I feel, what is the difference between, the literal meaning of Gyan is knowledge. So why does Gyan, if someone says Gyan bant raha hai, then why does it have a negative connotation, specifically with topics like this? Because in knowledge, when someone imparts knowledge, you take home with yourself certain insights and inputs. But with topics like this, neither the speaker nor the delegates go home with anything. So that's the reason these would be categorized as Gyan topics. Anyhow, nevertheless, even Dr. Venkat Goyal was joking at me a few minutes back. Thankfully, this topic went to you. So, nevertheless, what we would try and cover in this short and simple presentation is what are the modulating factors that contribute to altered pharmacodynamics of a drug. Is it the ECMO per se, or is it the disease of the patient per se that does it? And the common drugs that we would be worried about would be all the sedatives and analgesics, not much with the vasoactive drugs, but of course, few of the vasoactive drugs, antibiotics and anticoagulants. So these are the drugs that we should be focusing on, and the primer for all this would be the same: creatinine clearance, volume of distribution. Septic patients have altered metabolics, and inappropriate dosing can lead to either toxicity or treatment failure. And inappropriate dosing, specifically when it comes to antibiotics or antifungal, can lead to resistance. So this is the premise why we just need to understand and keep it always in the back of mind how our approach to dosing of these drugs will affect the outcome of the patient. Well, this is a general slide where, as I said, you have in a septic patient or in an ECMO patient, both the critical illness and the ECMO circuit both contribute to this altered regulation, which involves an altered clearance. Mostly there's an increased clearance in the early part of sepsis. Late part, there is decreased clearance. There is always an altered increased volume of distribution because of sepsis. That's the reason you find this patient bloated. And the circuit of ECMO gives an additional volume of distribution. And then there is the problem of protein binding, which a few drugs are very highly protein bound, specifically the drugs which have very good effect in the CNS system would by definition would have a very good protein binding. So you have certain circuit factors like the ECMO circuit per se, and that's because the surface area of the circuit leads to sequestration of the drug, and logically here an increased dose would be required. Then there are patient factors where unless and until your metabolic pathways or modes of clearance like hepatic or renal are not altered, again logically your volume of distribution is increased in the early part of sepsis. In the later part of sepsis, when in the early part of sepsis, the volume of distribution is always increased, but the clearance increases in the early part of sepsis. In the later part of sepsis, there is decreased clearance. Then altered pH in the circuit can lead to certain changes in the dynamics of the drug, and there is regional mismatch in the flow to the organs, specifically liver and kidney, which cause the clearance of the drugs. Now, lipophilicity is one of them. So, a few of the antimicrobials have very low lipophilicity, like your carbapenems, aminoglycosides. A low lipophilicity also means that its volume of distribution would be low. High lipophilic drugs would seep into your tissues, and hence the volume of distribution would be high. So, these high lipophilic drugs, the expected effects on ECMO would be maybe the concentration may be significantly reduced because it is sequestered if it has a very high volume of distribution, high lipophilicity, whereas low lipophilic drugs would not be sequestered in the ECMO circuit. This is again very logical. Likewise, drugs with low volume of distribution, because of the enhanced circuits, enhanced tubings and the oxygenators, and on top of that, if you add your filters and CRRT machine, they all increase the volume of distribution. And so drugs with low volume of distribution, the effects would be very less, very high. Whereas drugs with high volume of distribution, this is not very affected. This is again just an extrapolation of the volume of distribution with respect to the added lengths of circuit. Likewise, protein binding. If a drug is highly protein bound, specifically you have tigecycline, daptomycin, and the new drug that's been used in COVID, that is eravacycline. So these drugs are highly protein bound, and the expected effects on ECMO would be significantly reduced because it gets sequestered in the tubings, in the oxygenators. And drugs with low protein bound, like aminoglycosides and carbapenems, they would not be affected much. So, but if you want to combine, use your logic saying that any drug with a low volume of distribution would also be having a low, would naturally be having low lipophilicity is not true. So, if this is a busy slide which shows how to do what to do with respect to specific drugs. But why I keep on saying that logic flies out of the window is when you do the studies. So I don't have a pointer to show it to you. Do you have a pointer?
No, laptop itself.
Okay, the laptop. Okay. Yeah. So this one tells you about the antifungal extraction by ECMO. And you can see fluconazole as a drug, there is no change whether you use this is just a ECMO model where the patient is not used. So you can see fluconazole, the ECMO circuit has no change on fluconazole. So logically now, fluconazole, you don't require a dose modification. Whereas in micafungin, as time progresses, the drug is sequestered more and the amount of drug that you need to give doubles, or sometimes they have given 2.5 times. What is interesting here is, you see these echinocandins, micafungin, so you would again expect that micafungin would be same as caspofungin. But if you go back and do the individual studies, caspofungin doesn't need too much dose modification in ECMO, whereas micafungin you need to increase the dose. This is why there is no logic. It simply boils down to rote memory. And with same happens with voriconazoles. With polymyxin, you might have to go more than the required doses. Sometimes we have even given 15 lakh units BD, 2 straight doses just to achieve the serum concentrations. So this is just short and simple because there's no logic here. If you have to understand this, just take your textbook or Google and do give the dose as per recommendations. So the take-home message would be ECMO physiology in critical ill patients is difficult to quantify. Pharmacology of drugs is altered and this can lead to antimicrobial resistance. Specifically when you're dealing with drugs like voriconazole, vancomycin or any other aminoglycosides, therapeutic drug monitoring is advisable just to achieve a proper level of the drug. Thank you.
Thanks, Sambit. Just a few comments with respect to sedatives when you use on ECMO patients.
Yeah, I want
Use them as per the need by the patient rather than just limiting yourself to a particular dose, because this is of the fact Sambit has mentioned earlier, because of the absorption till the sites are adsorbed on the circuit or on membrane oxygenator and this dynamic equilibrium is achieved, till that time the drug will be needed at higher concentration, and once the sites are saturated then you won't be needing that. Again, if you have to change the circuit or oxygenator, then this process will restart once again. So that is one important factor to remember.
Yeah, specifically like, the same way here, sir, morphine and fentanyl. The fentanyl is, a lot more times potent than morphine, but the absorption of morphine and fentanyl are very different. So both of them are in the same class of opioids. So what we have seen is that when you mix and match or keep changing the sedatives, they seem to act better. Instead of running one kind of sedative all throughout the course of ECMO, if you go on changing them, they you tend to need lower doses over time. That's what we have seen.
Yeah. Pharmacokinetics were much more relevant in the days before 2005 when we were using roller pump ECMO. The circuit length used to be longer in those days, but once we are resorted to centrifugal ECMO, the circuit length is not that much. So the circuit binding also proportionately reduced. That's what we feel. Yeah. Any questions please to Sambit? Yes.
See, I agree with you that we need to have more drug levels monitored during ECMO or for that matter even otherwise. But very few antibiotic drug levels are easily available in most hospitals. That's a pity, because every lab says I can do any drug level. But then, like Mofussil bus, they wait for volumes. So there's no point in doing sending a blood sample today and getting the result after 10 days.
Yeah.
So we really need to evolve a better strategy for drug levels. I agree.
Yeah, even in Hyderabad, we only do drug level for vancomycin. That's the only thing available. Yeah.
The statements you make and the practicality are very different.
Yes, absolutely. That's that logic flies in the end of the air when it comes to this topic.
Well, one thing which I will never understand in my life is, if you consider a pharmaceutical name of a drug, the same medicine is available by different companies, made available by different companies. One company sells it for 2,000 rupees a vial and another one sells it for 20,000 rupees a vial. Which is best? Which is the good one? Which is the trustworthy one? Very difficult to understand from my point of view.
Indian FDA is also not reliable. The drug controller, who knows what the results are?
I think the drug levels, as Dr. Bala is saying, is very relevant, especially the type of patients you are dealing with. Heart failure. Heart failure, both the kidney and the liver functions are compromised. Now you put the patient on ECMO, everything normal. Now the excretion becomes more than whatever is going on, so the levels may change. So you need to be, especially the heart failure patients, or for that matter, sepsis patient, as you were saying, that initially there is an increased volume or increased excretion and then later on decreased excretions because of secondary effects of the organ dysfunction which can happen. But if you are giving high ECMO flows, high, whatever flows you are giving, that is going to be reflected also in the high liver flow, high renal flow, and will lead on to increased excretion of the respective drugs. Like if you are putting a cannula in the aorta, or the femoral artery. Now, and all the flows are going, the kidney is perfused very well, so more of drug is going to get excreted. So we need to have the monitoring of the drugs levels.
Thank you.
If there are no further questions, I thank all the speakers for their elegant presentations. Thank you very much.